Hello and welcome to Chairside Live. I'm your host Megan Strong. In this episode, we're giving you a look at another presentation from the inaugural Glidewell Dental Symposium. It took place in Dallas, Texas in November 2017. And this episode is featuring Dr. Timothy Kaczynski with his presentation, Aesthetic Implant Success. He's sharing his proven techniques for generating beautiful aesthetic results from your implant cases. This lecture will equip you with specific and simple protocols, providing you with the confidence and competence in placing implants, all to achieve those optimal restorative outcomes. Let's listen in.
Dr. Timothy Kaczynski began his career as a general dentist in Bingham Farms, Michigan, and quickly adapted to the rapidly expanding field of implantology. An expert in the surgical and prosthetic phases of implant dentistry, Dr. Kosinski teaches aspiring dentists at the University of Detroit Mercy School of Dentistry, serves on the board of numerous dental journals, and has published over 180 articles on dentistry. He's also the recipient of the Academy of Dentistry International's Humanitarian Award. Today, his presentation, Aesthetic Implant Success, provides an engaging discussion on proven techniques for generating beautiful aesthetic results for implant cases.
But before we begin, I have a question. How many general dentists do we have in the audience? Well, I'm one too. I'm a general dentist from the other D, Detroit, and you probably feel sorry for me that I'm from Detroit. Detroit's doing great, by the way, but we were hit with the economy very badly, and yet I've been very successful with my implant dentistry practice. I've been practicing implant dentistry for 32 years. I'm in the suburbs of Detroit, but our patients come to us in need. There's an incredible need for our patients to have implant dentistry today, but it doesn't have to be a $7,000 per unit event for the patients. Patients can't afford that. So working with the team at Glidewell, their outstanding implant department, we've created some things that I want to demonstrate. I'm just going to show you one case that I think all of you here are capable of doing, but we have to understand why we get the results that we get. So let's look at a clinical case. In your practice, this patient presents to our practices with a fractured tooth. He came from another office, already had a little flipper, a little transitional removable appliance replacing his central incisor. He was not in pain, but he heard about these implants. The internet changed everything, didn't it, with implant dentistry? Patients are very, very astute. Now, we have some aesthetic issues here, and I'm a big believer in my practice. I try to address the patient's concern. He has other issues. His concern is missing his front tooth, and he wants it replaced. Now, we have a CBCT in our practice, which gives us an advantage in diagnosing. You can see we have a tooth that has a very, very, very thin facial plate. So we have the tooth that we're going to remove. I think we all agree that it can be extracted. And we use some atraumatic extraction techniques, some tools that allow me to maintain the interseptal bone. Some of us here would take a periotome or a separator or a burr or a luxator or an elevator and try to remove this tooth. But I try to stay away from the interproximal area because remember, the interseptal bone is what's going to hold that interdental papilla. Let's see if we can do this. So I'm not going to go into the technique here, but we atraumatically remove this tooth. We try to maintain the papilla as much as possible, and we indeed maintain the facial plate of bone with this technique. So we take a digital radiograph and we can see we have a socket. We want to make sure that we don't have any tooth roots intact, and we make sure that we have a clean extraction. So what I'm doing is I'm taking that root and I'm simply measuring. I want to know how long of an implant I want. And again, what we try to teach is a recipe, the rules that you have to follow. We want to extend our primary burr, our pilot burr, at least 2 millimeters beyond the apex of that removed tooth. That's going to give us initial stability of the implant so it doesn't move around. Now, the first thing that we're going to do is we're going to take a pilot burr into that socket. But I said earlier, you don't place the implant directly in that socket. Why would that be? because the facial plate of bone is very thin, and I don't want to lose that. I don't want to blow that away. So we're actually going to place our pilot burr 3 millimeters palatal to the facial aspect of the adjacent teeth. And we can take a radiograph and we can see exactly where we are. We're again placing the pilot burr 3 millimeters palatal to the facial aspect of the adjacent tooth. Look at the interdental papilla. This is immediate extraction, immediate placement of an implant. We will take a radiograph to establish depth. We're following certain rules. We don't want to be too close to the adjacent periodontal ligament, right? So we look like we're pretty center. If you look at the incisal edges, the dark space on either side of that burr is fairly equal, right? So we're trying to establish emergence and contour of this tooth to make it look more natural. If we don't do this, oftentimes we end up having to restore the adjacent teeth with a veneer or a crown. Then once we establish proper angulation, positioning, and depth, stability, extending it beyond the apex of the root, we will simply widen the osteotomy. It's a brilliant system that is a simple system. These are side-cutting osteotomy burrs that will simply widen the osteotomy site. And then we will end up with a 4.3 diameter implant, so we're widening it one more step. The Hahn system, as I said, is brilliant. Dr. Hahn is a brilliant inventor, very practical a dentist. There's micro threads, there's a machine collar. The reason we have a machine collar on this rather than coating the implant all the way to the top is because Dr. Hahn, in all his years of study, realizes that physiologically we are going to get some bone loss around an implant. It's natural, okay? And this polished machine collar allows for a much healthier periodontal end result. So here I simply use a graft material, and I'm going to thread my implant right into it. The implant is aggressive enough, the threads are aggressive enough, that it's going to push that grafting material along the sides and fill that void. So we're placing the implant, and we ended up, again, I'm not trying to show you the surgical technique, I really want to show you the prosthetics, is we were able to torque this to 25 Newton centimeters. So I want you to look at this image, the schematic especially. The implant was not placed where the socket was. The implant was placed palatally to where the socket was, and it extended beyond the apex of that root. That's where we got our initial stability. I decided to bury this implant, so I just put a cover screw into the implant, and we allow it to heal. So you can see the placement of my dental implant on the sagittal view of a CBCT. I have plenty of facial bone. I'm not going to have a gray shadow there. I'm not going to have an issue there. The thinnest area is at the apex, which is 1.1 millimeters. So plenty of facial bone to create an aesthetic area. Now it comes to Glidewell Lab, and the technicians will do a CAD CAM. They'll make a model, they'll scan it as Doctor just demonstrated earlier, and they will fabricate a transitional or temporary abutment for me. Custom made. I'm a big custom abutment guy. I like contours. They will establish the design of the crown. They can communicate with me, and they're creating an ideal crown for me digitally. They make a composite temporary crown for me. Now let's look at the tissue. Let's look at the interproximal tissue. Let's look at the facial tissue. It looks good. We have good attached gingiva. So I did a tissue punch. It's just simply a round instrument, and I can see the implant, and I'll remove the little cover screw that we have, and I will immediately place the temporary abutment, the custom temporary abutment that was created by the lab. My margins are at or ever so slightly subgingival. You can see the position of the implant screw, the access hole, is about 3 millimeters palatal to the facial aspect of the adjacent teeth. These are rules that if you follow, you will get the same results that I get. I'm not creating this, I'm just laying a foundation for the lab. The laboratory will then send me a seating guide, which allows me to torque the abutments. Now, every implant system, the seating screws have to be torqued to a certain amount. With the Hans system, it's 35 Newton centimeters. You can't break that rule. Has anybody here had an abutment come loose under a crown? I have, and it happens. But if with the new technology, with these new torque-tight screws, that's not going to happen as long as you follow the rules. And this is the temporary. Big deal, Kosinski. It doesn't look that good, you know, but it's a temporary. Well, if you simply get up, go have a cup of coffee or go make a phone call or check your emails, in a matter of minutes, it'll start to close down. It's physiologic. It's the body's response to what we're creating. After a couple weeks, you can see how that interdental papilla, at least on the mesial aspect, has filled in, correct? The distal, it's a little bit more of a challenge, and we have to decide how are we going to address that. Do we do something with the malposition lateral incisor or not? In this situation, we're not going to. We're going to deal with the patient's main concern. But you can see how the tissue starts to heal with a temporary restoration. Our margins are at or slightly subgingival. This is the impression coping, and I will do, again, a standard polyvinyl siloxane in this situation. And I replace the temporary abutment and the temporary crown that we created. Look at those margins. The laboratory then has an ideal final impression with tissue contours that mimic a natural tooth. We're creating emergence profile to hopefully create smile design in the aesthetic zone. Look at the tissue. The tissue response is amazing. We get a beautiful gingival cuff in that area. Glidewell Lab will then fabricate for me a final zirconia Bruxer abutment, which is very strong, very capable. We are going to torque that abutment screw at 35 Newton centimeters. When we do that, I feel very comfortable that that abutment will not come loose and we will have an outstanding restoration. This is the final crown. This happens to be an Emax crown that they created immediately after placement, okay? And this is not something that I created. The expert techs created it. And they created it almost exclusively with CAD/CAM technology, with milling, as we just saw. The interdental papilla in the mesial aspect is what I expected because I had enough bone to be able to do it. So the final smile, I think, is very satisfactory for this patient. I think we established health, contour, aesthetics, and we met every one of the patient's goals. Thank you, everybody.
Thank you, Dr. Kaczynski. To see more of the action from the symposium, you can head to chairsidelive.com and check out some other presentations for more of the talented speakers that hit the stage. Well, that about wraps it up for this episode of Chairside Live. So on behalf of everyone here at Glidewell Dental, thank you for watching, and I'll meet you right back here next time.